Hi friends, I'm Dr. Ashutosh Gupta and I'm a consultant in fetal medicine. So today we are going to talk about how do we navigate and how do we do a differential diagnosis whenever we identify that one of the ultrasound findings is abnormal, right? So in our case, what we are having at the moment is an increased nuchal translucency, right? So how do we navigate on the ultrasound itself, putting up all the differential diagnosis onto the fetus and reach to a logical conclusion as far as the pregnancy is concerned, right? So look around, hyperextended legs, okay, fixed position and the tone is more. And then we see a strawberry skull, reversal of A wave in ductus venosus, which is under evaluation. So on TAS, we are seeing suspected VSD and a large univentricle. So that needs further evaluation, right? And then we are seeing the fingers. So this is clenched fingers, both the hands. So baby is really not willing to open up the fingers. So the baby's hands are clenched. And this is the increased nuchal translucency, just short of a cystic hygroma. And so probably cystic hygroma we can talk about it, but it is increased nuchal, and then the fingers, the baby is not opening up the fingers, right? Okay, so the clenched fingers, and then we see for the strawberry, so this is strawberry skull, then the cardiac large VSD, and then we can identify that both the great vessels are rising from the RV, so this is the DORV, right? So this is DOR. So the findings at hand was an increased nuchal translucency pehla, right? And then we started to evaluate the baby, and then we identified that the limbs are sort of an hyperextended in a fixed position. So meaning thereby that the tone is higher. So probably the first differential that came into our mind was a neuroarthrogryposis. So this could be multiple pterygium syndromes and sort of an FADS, fetal akinesia deformation syndromes, and so on. And so meaning thereby that the neuroarthrogryposis can very well explain a sort of an increased nuchal translucency. Then we started the evaluating the baby further up, and then we identified that both the hands were clenched, right? So the baby, even though we try to shuffle up the baby and we try to stimulate the baby by, but the baby during the period of examination never opened up the fingers, and the fingers were overlapping and clenched. So suspected of an increased tone. And then we saw the strawberry skull. So, and then there was a reversal of A wave in the ductus venosus that showed us that there could be something with the heart. On a TAS, transabdominal ultrasounds, we identified that probably it is a big VSD, and a suspicion of a univentricle was there on a TAS. So when we took up the baby on a TVS, we identified that we corroborated the finding that the VSD was there, and we could delineate that both the RVOT and the LVOT great vessels, they were arising both from the right ventricle. So that was a DORV. So meaning thereby that putting up all these things into the context, so meaning thereby that we do have a strawberry skull, clenched fingers, both hands, hyperextended and an abnormal position of the limbs, and a cardiac malformations, DORV. So this was a case of a trisomy 18 or an Edward syndrome. Now, what happens is this, that with this trisomy 18, this NIPT and CVS, they really don't work. Why is it so? Because placenta might have 1 to 2% possibility of having a confined placental mosaicism. So whenever we are identifying on ultrasound that we are suspecting a trisomy 18, right? So it is always better to wait it out and do an amniocentesis, because if you do an NIPT by looking around for fetal DNA in the mother's blood, what can happen is this, that it might lead to a false positive, or could be a diagnosis of trisomy 18. For confirmation, if we do a CVS, might be a false positive trisomy 18 because of the CPM. So the best test available whenever the clinical suspicion for trisomy 18 is there, so which it is an amniocentesis, and neither the NIPT nor the CVS, right? And therefore this one sort of an ultrasound finding of an increased nuchal translucency really took us from sort of a neuroarthrogryposis to Downs to aneuploidies to cardiac and ultimately trisomy 18. Okay, thank you very much for your patience.